Hello and welcome to Health Matters on Channels Television. Thanks for staying with us. I am Mary Alale Yusuf. As at May the 23rd, the global count of confirmed COVID-19 cases was over 5.2 million. Recoveries topped 2 million, and sadly, there were more than 338,000 deaths. The United States of America had more than 1.6 million confirmed cases, representing about 31% of cases worldwide, and is almost 5 times the caseload in Brazil, which in the space of 24 hours overtook Russia as the second hardest hit country. In the same time frame, Nigeria's cases had gone up to 7,261. There were 2,007 recoveries and 221 deaths. Lagos had 3,224 confirmed cases, representing about 44% of the Nigerian total and almost 4 times the reported cases from Kano, the second hardest hit. My guest is Deputy Director of Research at the Nigerian Institute of Medical Research and Head of Infection Control and Biosecurity. He's also a consultant obstetrician and gynecologist. You're welcome to the show, Dr. Gregory.
Thank you, Mary. It's good to be here.
Let's get into it. I'm concerned about this second wave that countries are talking about. Why should they have a second wave? What is it?
Yes, Mary, it's true that that's a real cause of concern because of the nature of diseases. There's a pattern that diseases go through, and it's important to understand that. You see, when a new infection comes into a community, for that community that is new, and for COVID-19 is new to the world. So that's the first experience. And because there's not been any previous immunity for that particular disease condition, it's going to spread like wildfire. And that's what has happened in this case. But due to seasonal changes, temperature changes, environmental influences, and genetic variables, this disease may change pattern and either recede or really move forward and become more aggressive. Now, that phase when the disease recedes and goes backward and things become better, that may be the end of the first phase. But disease may come back more aggressive for 2 reasons. One, seasonal condition has created an ambience that is suitable for the disease. 2, the virus, in this case for COVID-19, may have mutated in that sense, of undergone genetic changes to make the virus more aggressive.
We're hearing that has already happened.
Yeah, and when it comes back, that becomes the second wave.
Okay.
Now, what is the cause of concern? Historically, from pattern of diseases, second waves are more aggressive because, like I said, the virus has mutated, so the immunity that was previously acquired, is not ready for this new wave.
Okay.
So it's more. 2, generally, health infrastructure may not be ready because, they may feel as if they are caught unawares. And so that disease may run a very aggressive course. Now, because of this experience, epidemiologists, scientists, and researchers are aware of this. And they are preparing that should this come up, we should be prepared in terms of our health infrastructure, state of preparedness, all the measures we put in place earlier. We should be one step ahead of disease conditions so that the debilitating effects will not be that bad.
We haven't reached our peak in Nigeria.
Yes.
Can we, at this point, even while we're still trying to flatten this curve, be preparing for a second wave? Yes.
In fact, that's the right thing to do. The essence of public health measure is to prevent diseases, not to wait for it to come. Now, what are the things we can do as a country? One, we can begin to look at some of the experiences we have from the data and let science lead and see the pattern of the disease. We should look at the symptomatology, and we should look at the morbidity rate, look at the mortality rate. We should look at our health infrastructure. We should look at measures for infection control that we've put in place now and ensure that those things are still in place by the time the second wave comes. A lot of countries, developed countries, are already thinking about the second wave. The CDC in the US is already putting structures in place for the second wave. They're already warning people ahead. Europe is looking at it, and so we should not be left behind. But I really hope that in terms of vaccine development, that we would have moved further and be able to prepare better for the second wave of the disease when it comes, should it come.
There's been a lot of talk about unreliable rapid test kits, you know. Currently, Lagos is verifying some rapid test kits. How sure can we be of these rapid test kits? Is there a way of knowing that they are genuine ones? Or is it just a matter of, you know, the person testing who doesn't know how to test or who knows how to test?
Okay, that's a good question, Mary, because you must understand the thing about test kit is that there are certain variables. I won't go too technical, but ultimately you're looking at the validity of these tests, and there are things like what we call sensitivity of the test, specificity of the test, and I'll put it in simple terms. If a test says that a person is positive, how true is that person positive?
Exactly.
If a test says that a person is negative, how true is that person negative? For what we know now for most of the rapid test kits that are being used, they have a 50% false negative rate.
That is high.
Yeah, that's 2 digits. Now, what's the implication? The implication of that is that if you test 100 people and you declare them negative, 15 of them may be false and they may actually be positive. Those people will become bricks to their, and give them a false sense of confidence, become bricks to their immediate community, to their families, to the extended community. So that's the worry about the rapid test kits. You know, that's why the NCDC, you know, is quite slow in adopting a lot of these rapid test kits. The test kits we are using now, they are very accurate. I mean, they border in the neighborhood of about 100% sensitivity.
You're using molecular tests,
yes,
right?
You know, yes. PCR,
Yeah.
yes.
But how do you verify? You make sure that a test kit, a rapid test kit that you want to adopt is actually genuine and will give you a high percentage of correct information.
You see, the thing is that there's a limit to the test kits by the way they are made. So at the end of the day, it's not, I mean, you may have a genuine test kit, but the capacity of that test kit to test is that the false negative rate is about 15%. So it doesn't mean that the test is bad.
Okay.
So it just means that in 15% of cases tested, you know, you are going to get a false result, particularly if you have a false negative rate. So, yeah, it can help a bit in terms of improving the widespread availability of the test kits. You know, the number of tests you can do will increase, you can upscale tests, you can test a lot of people. So that's the benefit. But the downside is that you're going to give people a false sense of confidence. So trying to strike that balance, you know, between when to deploy it, and that's where you should allow science also lead. They're going to be, I suggest that there will be carefully selected criteria for when they're going to use those test kits, rapid test kits. I'll give an example. Like in the case of, you know, the people that came in from outside the country, the people that were evacuated back to Nigeria, that could have been a very useful tool, just to give you an idea of what is happening in the community, you know, this community of people, and say, okay, what's the rough percentage of people that may be positive in this instance?
That's plus isolation, right?
Yes, that plus isolation. So you have an idea of what's really happening. So it will be useful, but it should be deployed in such a way that it will not mislead people, it will not create a false sense of confidence. There's a place for it. You know, they're using it in the US and in other places, but it should not become the standard of care. There should be a way to also triage and ensure that accurate results are obtained from the standard.
Okay, so let's look at antibody testing from convalescent plasma. So you are able to check for antibodies in the plasma. Can we do that now in Nigeria?
Yeah,
and how does that translate to a vaccine?
Well, there are two different things. So I'll discuss it separately so that it will be clear to everyone. Now, there's antibody test, there's convalescent plasma, and there's vaccine.
Okay.
So I will go take it one after the other. Now, the aim of antibody test is that it helps you to know the number of people who have been exposed. So it's a very useful test. It's going to help in reopening the economy and reopening the society. So if, for instance, I know that I'm exposed, I know that to some extent I have some degree of immunity to the virus.
Is this exposed and recovered?
Yes.
Or exposed and infected?
No, exposed and recovered. Exposed and recovered. So you'll be testing negative by the PCR test.
Okay.
But by the antibody test, particularly the IgG antibody, positive, which denotes chronic immunity that I've built over a period of time. So you'll be testing, positive to that, but that's what the test will do. It will help to reopen the economy. So those who can go back to work, those who are ready, to face life generally, and the extent of protection they have. Although one should be careful, like I said, this is a new disease. So scientists are not even sure the extent of immunity that we acquire, how well it will protect us for, what is the duration. So it's something that we are still studying. But the antibody test is a useful adjunct because it's going to help a lot of communities, a lot of societies to open up. It's going to guide the way people open up back to normal life. It's going to be very useful. And who is already exposed, older people that are exposed, all of that. Then I said the second thing I said I will talk about is about convalescent plasma. The convalescent plasma is that because those who are exposed have already built antibodies against this disease. Now that antibody they built can be used as a form of therapy to those who have not been exposed. So there's a research, there's a clinical trial going on now that is using convalescent plasma as a form of therapy. So it will be useful in that regard. It's used in other diseases, and we expect that based upon that principle of immunology, it's going to be useful in this instance to treat. How
soon can that be ready? I mean, if it's effective?
Yeah, people are already using it in clinical trial settings.
Okay.
Some clinicians are already trying to use it, but it's not yet the standard of care. But it's something that by the time results come out and it shows promises, it will be a part of the armamentarium for the care of patients. Then the last thing I'll talk about is vaccine. Well, the good news is that the progress on vaccine is good. As we speak right now, there are over 100 vaccine in clinical trials. The one from Oxford is progressing very fast. The Professor Adrian, he is leading that research. Recently said that they're trying to go into phase 2, phase 3 clinical trials, and they're ahead of everybody. The
phase 3 is human, right?
Yes. Every aspect of clinical trial is human. Phase 1 is when you are testing the safety of the vaccine. Phase 2 is that you are testing the efficacy.
Okay.
In most cases, phase 1 is if you're using drug, you're using it in healthy people, while in phase 2 you're using it in people who already have disease, but the vaccine is a bit different. But everything clinical trials to do with humans. So they are making very good progress. But the good news from the vaccine story is that we've seen neutralizing antibodies. So that is huge.
Okay.
Really huge. And it says that the fact that there's neutralizing antibodies from the test so far shows that there's potential for it being effective. HIV, for instance, we'll not be able to discover neutralizing antibodies for it. So this is a huge step. And that, I think, is the biggest story that has come out of the vaccine development of late. So we'll see who will be the first person to produce a vaccine that will be effective. Oxford seems to be leading the charge now. And then by the prediction of Professor Adrian Hughes, he's looking at September, October, we should be able to have this vaccine available if everything works as planned.
Oh, that's great. Let's talk a bit about this new idea of home isolation.
Yeah.
The thing came up because, probably bed spaces are becoming tight.
Mm.
And then also, some people who test positive run away rather than wait to be picked to the isolation centers. So they said, okay, why don't we do home isolation? But how safe is home isolation? Let's wait till after the break. Okay. We'll answer that question when we come back. Please stay with us. After the break, we're going to hit that question. Welcome back to Health Matters. We are discussing COVID-19, and here are some emergency numbers you can call if you need to get to somebody to talk about your symptoms. Now, the number to call if you have questions about COVID-19 today is 0805-468-3514. It's appearing on your screen right now. You can also tweet at CTV_Mary A for your questions. Let's get back to this idea of home isolation. What do you think about it?
Yes, Mary, see, home isolation is something that is inevitable. Mm. But what we should concern ourselves about is how is it practiced? You have to look at our population density and look at our households, the average number of persons per house, per room. So those are the variables we have to look into. This is not new to the world. In developed countries, in the US, in Europe, it was something that they had to consider. By the time you are dealing with hundreds of thousands of people being infected, you possibly cannot keep all of them in a health facility.
Those countries, those areas, they had more consideration to their planning, their town planning, their city planning, so they have bigger spaces where these things can be done.
Yes, well, our case is even unique because, like I said, because of our population density, because of our housing challenges that we face, it's something that is inevitable. But we have to look at selection criteria for people who qualify for home management. Remember that this is a disease that in over 80% of the cases, people will have very mild symptoms.
Yes.
In fact, there's a recent data I saw that showed that close to 40% will be asymptomatic. I mean, so and 80%, will have very mild symptoms. Another 10% will have some moderate symptoms. And looking at less than, probably 10% of people, very single digits that will have severe symptoms. So definitely there's a place for home isolation. And in some cases, in some of these isolation centers, the patients are not receiving any medication.
They are not?
Yes. I mean, they're not receiving any medication. Some of them are not giving drugs per se because they are really asymptomatic.
Okay, so the whole idea is just keep them away from circulation.
Yes, and watch how their disease will progress also.
Okay.
Because from being asymptomatic, somebody can become symptomatic. Remember that there's no treatment yet, official treatment for COVID-19. Most of the care that is given, standard care, is supportive. There's no official treatment. People are trying a lot of things and nobody's sure. So nobody is really, there's no official treatment for COVID-19 as we speak. But the point I'm trying to make is that there are cases that are asymptomatic and they can be managed effectively at home. Now, but the concern is that will they adhere to the instructions? Will they keep...
Let me just cut you briefly there and take Mary on the line. Hello?
Hello.
What's your question, Mary?
I have a question and I also have a contribution.
Ahead.
Now, we find out that the treatment of COVID-19 in different centers is not the same.
Okay.
According to the patients that have been discharged, meaning that treatment is the prerogative of whoever is treating them.
All right. So we'll find out why that is happening. We have to get right back to the doctor. They say that there's a testimony.
Yeah.
People who come out talk about different kinds of treatment. It's not the same.
Yeah, that's the point I was making earlier, that when you're asking about home isolation, that there's no official treatment. So there's a lot of latitude for the clinicians to use their discretion based upon the way the patient is presenting, because there's no official treatment yet for COVID-19.
But there's symptomatic treatment.
Yes, so you have fever, you give antipyretics, you have cough, you feel that the patient is having increased risk of opportunistic infection, you want to use antibiotics.
Okay.
People have talked about the use of hydroxychloroquine, the use of chloroquine, but these are all drugs that are not proven. And again, there are research work coming out now that shows that chloroquine, first of all, is not effective. Two, it may even be dangerous to some people with cardiac side effects, associated with it. So these are things that are areas of concern that we should look at. I'm trying to talk about the fact that for home isolation, the worry is that patients may not comply. They will maybe not use their masks, they may not adhere to the regulations that the NCDC may give to them. And the population density per home may be so high that it may be difficult to achieve that. So I want to round up on that so that I can focus on the aspect of treatment. I think the advice is that there should be carefully selected criteria for patients that they want to give home isolation, they want to use home isolation for.
People who they feel
it should be, and there should be a mechanism for monitoring them and ensuring that they comply.
Okay, let me quickly take Samson on the line. Hello, Samson.
From spreading wide. But now,
Samson, are you there?
Hello, can you hear me?
We can hear you, Samson.
Yeah, in Nigeria, during the lockdown that people were at home, there is a declaration of new cases in Nigeria. Why is it that way? Because I know that the purpose of the lockdown was to prevent the COVID-19 from spreading. But you wake up in the morning, you see new cases. So how can we balance it?
Thank you, Samson. I'm sure the doctor can respond to that.
Yeah, I think Samson was trying to say that there's still increased cases. And
that during the lockdown,
yes,
there were still new cases.
Yes.
Why? He thought that the lockdown was to stop the thing from spreading.
No, because the testing process was on, disease was already in the community. And finally, the people were not adhering fully. So, I mean, those are the three factors that I would say, led to
But
the increase in
during the
cases.
lockdown,
Yes.
even if people had adhered fully, they could have had some spread within homes.
Yes, because there was community spread already, and we were doing more testing. So the cases were already there. So we're just picking it out. So
let's quickly get this out of the way. I've been hearing reports about COVID-19 in cats, in tigers. What are we to do with animals, especially if somebody is on self-isolation? Can an animal spread it around the family?
Yes, pets. Yeah, because they're mammals, they're animals, so they can also have the disease. Like, I think there was a case reported in a tiger in a zoo, and it was thought that the caregiver for the tiger, actually gave the tiger the infection. So if you have pets
goodness, from human to animal now.
So that was the first reported case of COVID-19 spread from human to animal. So if you have pets at home, and they can also be vulnerable. But again, remember that the way the virus will process, the way the animal will process the virus may be different from the way human beings will also process it.
Well, it doesn't matter. As long as the animal doesn't give another human being the thing, then it's fine. So personally, I'd get rid of my pets if I was on self-isolation. Thank you so much for coming to the show. It's been wonderful having you.
Thank you,
we have
Mary.
to close here.
My pleasure.
Thank you so much also for being there with us. Your calls, they are so precious. Mary and Samson, please stay safe. Wash your hands. Stay away from crowds. Do not forget your mask when you're in public. Thank you so much. I am Mary Alale Yusuf.